Our research really revolves around a problem that chief medical officers have. They open up the morning paper and they find that their hospital's been ranked very low in some quality of care report. And their initial reaction is always, our patients are really sicker, and that's why we look so bad in the reports. This research, template matching, tries to improve the reports so that there's a fair comparison across all hospitals. And we really tried to look at the problem in a different way using multivariate matching, which has never been done before in looking at quality, to be able to fairly compare hospitals, and then the chief medical officer wouldn't be as upset because he'd probably believe either there was a problem or he'd look good in the reports. Template matching is a new way of looking at the way hospitals treat patients. The usual problem when we compare hospitals is that we say, here are all the patients that you saw, and then if your patients were going to be going to another hospital or the typical hospital, how would they do? That's a strange way to compare hospitals because each hospital has a different set of patients. And so it's really not a fair way to compare hospitals because one hospital might have an easier set of patients. We're going to make some adjustments, but they still have a very different set than another hospital that might have a much different, more difficult set of patients. What we decided to do was create a template of patients, meaning a set of patients. In our case, it was 300 patients with general surgery and orthopedic surgery. And we said, let's take a relevant template and then match at each hospital their patients that would fit the template. So we ended up with 300 patients being matched at 217 hospitals. Now we have very similar patients at each of the hospitals because they've all been matched to this cookie-cutter template, which is producing very similar patients across hospitals. So now we can make a very fair comparison because we're looking at the same, in a sense, 300 patients at each and every hospital, which is completely different than the way almost all report cards are made today, where they look at the patients at an individual hospital, then they try to estimate how would they have done at other hospitals, where each hospital has different patients. So we're completely changing things around. The technique is, and there's another word for it called direct standardization. And what we're doing is saying you have to have a fair exam. The fair exam is how did the hospitals do on these 300 patients? We find the hospital's 300 patients that look like the template, and that's what we compare across hospitals. So now it's very hard for a chief medical officer to say our patients were really sicker than another hospital. It's very hard to do that because the patients we're going to be examining at their hospital are the same 300 that are at each and every other hospital. Same in the sense that we have multivariate matched them, which means that we've matched them on literally hundreds of characteristics so that they're very, very similar, and their risk of doing poorly or their chance of doing well is very, very similar across all the hospitals. What we say in the paper, what we show in the paper, is that these 300 patients at each and every hospital are incredibly similar. Their age is the same, their rate of diabetes and heart failure and all the other characteristics we'd be interested in are incredibly similar, statistically undifferentiable to the other hospitals. But yet, what we find is that the outcomes are very, very different. I think that there are two key takeaways. The first is that we can do the matching. And what we showed was that you can get very close matches across hospitals, each hospital stamped out to this template of patients. The second is that there's just great variability in the way the hospitals handled the patients and the outcomes of the patients. And I think seeing that the matches were so close and at the same time seeing that the outcomes were so different was something that I think people should realize, that there are differences in quality across hospitals and that there are, I think, better ways to measure them than what we've been doing up to now. Probably the biggest surprise was that after we did this very close matching, such that all of the hospitals had an incredibly similar sample of 300 patients, there was great variation in outcomes. Some hospitals had high complication rates, some had low complication rates, some had high mortality rates, some had low mortality rates. Things that when I would see this in a standard report, I might not believe because I knew the hospitals were seeing different patients. But here, after having matched so closely to see this great variation in outcomes, I think that was an eye-opener. We've given that some thought. We've usually been applying this technique to the hospital sector, but I think you could easily apply this to nursing home quality, schools. We could imagine creating a template of students and stamping the students out across different schools, seeing how the student outcomes were. So yes, you could use this technique in other areas. I think the key here is that we're taking from one field, which is from statistics, and in particular multivariate matching, for which Paul Rosenbaum is the world's expert in that area, and we're applying it to quality assessment. And I just don't think that's been done, and it certainly hasn't been done with a template which kind of levels the playing field and lets you really see if your quality is different than others. I think the biggest problem is that people tend to believe report cards based on what's called indirect standardization, where we're looking at different patients at different hospitals, different types of patients, even non-overlapping populations, and saying that we can extrapolate from the models to say that one hospital's quality is better than another. I think that's a misconception. I don't think that the models currently allow us to do that. And that if we had better techniques, and I think this is one of them, we'd be able to at least provide confidence to the reader, both the user in terms of the patient and also the people at hospitals that are trying to improve safety and quality, that there really are differences or not. And I think that's probably the main point. There are many groups that are grading hospitals. The federal government, it's called Hospital Compare, the website that lets you click on a hospital and compare it to another hospital, has been doing this since 2007. There are many different organizations and web-based companies that grade hospitals. They often look to Hospital Compare, which is the main model. For example, Consumer Reports looks to Hospital Compare. Hospital Compare suffers from these same problems. It suffers from using indirect standardization in the sense that it's kind of taking what the patients the hospital saw and making an extrapolation about how they would have done at another hospital. And so I think that if that could be changed, that would be a great benefit to the application of looking at quality. Often hospitals have access to national data sets or comparative data sets. So hospitals could, in a sense, form their own templates and then see how their patients would do at other hospitals using the same technique, but they'd have to understand the details of multivariate matching. We bring to the table a way to do this in a very, I think, sophisticated way through the work of statisticians at Wharton, in particular Paul Rosenbaum. But if they could do that matching, then they could better compare their results to other hospitals and know whether they're really doing a good job or not. I think a second area that we actually just talked about was this idea of making your own boutique template. So a chief medical officer could, for example, say, let's construct a template on these difficult patients that we see, and let's see how other hospitals would have handled these same difficult patients. I think that boutique template is a way that is the next step, and that's where we're moving. And then there's other applications of multivariate matching to looking at quality. Suppose you have a very small hospital. You don't match the template very often because you're so small, you don't have the patients to be able to match to this overall national template. Well, we can turn things around and we can say, okay, let's look at the small hospital's patients and then match them to the whole country. So use the whole country as a kind of a frame of reference. And then we have a very good idea looking at the outcomes of the small hospital's patients and their matched sample, how the small hospital did relative to the typical patient in the country. So that's another application to multivariate, with multivariate matching to help improve quality.